and I'm going to talk to you on Phaco and subluxated cataracts. So these are 2 o'clock hours of subluxation, you can see here, and 4 o'clock hours and 180 degree. Okay, so for each of these, you need to have a game plan. You need to have a plan A, plan B, plan C. As far as subluxated cataract is a totally different ball game, and Phaco is probably one of the safest procedures in this. So surgical planning, you can do the capsular tension ring, to use or not, use before or after Phaco, size to use, type to use. So less than 1 cataract. This is the rule of thumb. The broad rule of thumb is IOL meridian. That if less than 1 cataract, you put the IOL, preferably a multi-piece lens in the meridian of the IOL, in the meridian of the loss, and then you can have a CTR, standard CTR. 1 to 2 quadrants, you can have CONE or 1 or 2 eyelets, and CT segment, IOMET segment can also be done. 2 or 3 quadrants above, we do a complete removal of the lens, either by the means of Phaco or SSA or whatever you are comfortable with, then put a glued IOL or a scleral fixated lens for that matter. So you should know the different sizes of the CTR and whatever it is. So I'm going to show you this. One of my old videos, the quality is not so good. You can see a 14-year-old boy, stone injury. I can see here I'm doing a scleral incision in this particular case. You can see the subluxation is almost about more than 5 to 6 clock hours inferiorly. But most important, because the most important problem in the subluxation is to do a rexis. Why? Because there is no peripheral resistance when you do the rexis. Okay, when you do the rexis, there should be some peripheral resistance for you to complete the rexis. Even to pinch the capsule and turn it around, it should be so difficult. And that is why I think femto plays a major role as far as subluxation is concerned. You can see here, I'm doing the rexis, and I'm supporting the lens with iris hooks. Ideally, the capsular hooks are probably better. Why? Because the capsular hooks rest on the equator, and they don't give what you call stress on the capsular rexis margin, whereas iris hooks can be used, but many of us use only iris hooks, but capsular hooks are a little bulky. But you can see here, the Phaco is not a very major issue because it's a very soft cataract, young boy, and you can see here, I'm doing a bimanual IA. When you have a CTR in place, okay, the problem is to remove the cortex, okay. So you need to go circumferentially, otherwise you can go radially, you need to go circumferentially along the equator. So what I'm doing is I'm putting this thing, in this case, I'm putting a CTR with a CONE. The reason why I'm putting a CONE is that you can see the subluxation is quite a large subluxation. It's about 180, almost 180 degree, or less than about 5 to 6 clock hours. And so I'm putting a CONE ring there, and you can see here how I'm threading that needle, and all this, everybody is doing that on a regular basis. But more importantly, you can see here that I'm doing this thing, and then once you put the CTR there, I'm going through it very fast, and then after putting the CTR, as I told you, removing the cortex is going to be a challenge. Okay, that is why you say put as early as you want to, but as late as you want. Okay, so CTR, normally I put the CTR in subluxated cataract once I remove the cortex or before I remove the cortex, because cortical removal is becoming a challenge. Okay, normally when you pull the cortex radially towards the center of the pupil. When you have a CTR, you pull it circumferentially along the equator. Okay, that is the big deal, and use always bimanual. That is always better in this case. So this patient also did very well. This is a tennis ball injury. You can see here, and this is one of my anatomy professors who had other eye was a ambulopic eye. You can see here what I'm doing is, you can see here the subluxation inferiorly. You can see the subluxation inferiorly. Again, rexis is a challenge. Okay, don't put too much of trypan glue. Why? Because the trypan glue can go through the subluxated area and stain the vitreous, and instead of red glow, you will get a blue glow, and the entire surgery will be very, very difficult for you. So what I'm doing is I'm putting a CTR after that, because in the beginning itself the lens is quite wobbly as well. Then I try to do a Phaco, the lens moves around, then I put iris hooks for on all the 4 quadrants. Please understand, watch this case very carefully. This is something learned from mistakes, like what Partha and Chitra was telling in the morning. You have to learn from mistakes what other people do. So you learn from the mistakes. So iris hooks, okay, if you're going to use iris hooks, please understand these iris hooks are going to rest on the capsulorhexis margin. Don't have the iris hooks too much traction for too long a time, because they can tear the iris hook. Look at these iris hook which is there. You can see I'm doing this thing. Look at I'm showing the arrow, the left, the superior iris hook, you can see here how it's giving so much of stress on the capsulorhexis, it opens up. Okay, it tears the capsule, and what is happening to the tear? It's going across the equator into the posterior capsule as well. So now I am in double trouble. I have a CTR there and I have a PC tear as well. Then I put a lens in the sulcus. In this case, I put a multi-piece lens. I do the holder-folder technique, and then I do an anterior vitrectomy to the pars plana, and the patient had 6/9 vision postoperatively. So you can see here. This again, this Jallikattu injury is quite common, especially this season wherein the Bulgur, there is a Bulgur, the bullfight which goes on in Tamil Nadu, is a very popular sport. So this is again a subluxated cataract. So don't be overconfident. See what is happening. I planned for a glued IOL in this case. I put a scleral fixation, the two rectangular flaps 180 degree. I thought I'll be able to remove this the very soft cataract, young fellow. So soft cataract, can see what is happening. Entire thing is gone there, back into the vitreous. Okay, because obviously there is no support and the entire thing went inside. Don't fish out these cataracts, because you can end up in a giant retinal tear. So immediately what I do is do an anterior vitrectomy, do a glued IOL. Already I have a pars plana infusion there. Okay, and then I go through, make 2 more ports and do a vitrectomy, 3-port pars plana vitrectomy, and the patient did very well. This is a 1-month post-op. See, what is happening is, I'm not advocating if you have access to the femto. See this patient, this is a 24-year-old girl referred to me from Saudi Arabia. She had a macular scar as well, road traffic accident. You can see the gross subluxation. It's a traumatic cataract. The zonials are there, but it is not fully intact. That's the thing. But the zonials are there. You can see here. The femto makes the life very easy. The reason why, because the rexis is already done. The lens is being split into it's pre-chopped. So you need to go in. Obviously, this is a patient, young patient. It's a soft cataract. So it made life easy for us. You can see here, I'm putting a CTR. So once I remove this thing, I'm putting a CTR which supports that inferior area. Then I'm putting a Technis single piece lens into the bag, okay, into the bag. And then the patient has got traumatic mydriasis as well. You can see the iridodialysis as well, all because of the road traffic accident. So don't leave these pupils large. If you're going to make these pupils large, you're adding fuel to the flame, because the patient is going to have glare and loss of visual acuity, loss of contrast, night vision problems. All these problems can occur. So I'm doing a single pass 4-throw pupilloplasty, which is advocated beautifully by Amar Agarwal and makes your life easy. And this patient also did very well. Again, this is another patient. Shuttlecock injury is probably the worst injuries you can ever have, because the shuttlecock, the smaller diameter, it can hit the eye, can produce a lot of problems starting from the anterior segment to the posterior segment. So again, you can see here, I'm doing a femto in this particular case. The advantage is this, you can see here, the femto, this is a mature cataract. Please don't underestimate the versatility of the femto missions. You can go penetrate through the cataracts as well. Even mature cataracts, you can see that I'm staining, I'm removing the capsule. Already it's pre-cut for me. So already the patient has got traumatic mydriasis as well. So I'm going through the cataract. I'm supporting that area of the zonal dialysis with the iris hooks. Every time you come out of the eye, inject visco into the thing and make sure that the gap, the chamber does not collapse, the bag does not collapse. Okay, that is very important. I'm putting a multi-piece lens. In this case, I put a multi-piece lens into the sulcus and then capture it into the bag. The reason why, because I don't want this lens to move around in the bag, because there was a little more subluxation than what I anticipated. So I just put it and captured it into the bag, and then I went ahead and did don't forget to do the pupilloplasty in all these cases. You can see here at the end of it, the The pupil is patient's got 6 bar 9 with a pupil size of about 3 millimeter. Again, another patient with ectopia lentis. How much time I have? I don't have much time. Okay. Anyway, this is a patient with ectopia lentis. I'm going right and putting the sink. We can see the single piece lens. But as I remove it, what is happening? Through the zonules, the vitreous is coming out. You can see this is a patient with ectopia. Immediately I switch over because obviously this lens cannot stay in the bag there. So this patient, I had to remove this lens and go to the glued IOL, and the patient had good. Again, another patient, Morgagnin cataract, subluxated. This is a huge problem. You say, can you use the IOL scaffold? Problem is subluxated as well as Morgagnin cataract. And this patient, I used the capsular hooks. I went ahead with the surgery without any problem at all. So this is something which you can think and make sure that all these parameters are gone through. Again, this is a very gross subluxation. I did a pars plana lensectomy and then a glued IOL, young patient, a 10-year-old female who had a stone injury. Again, I am not going through this thing. The take-home messages are very, very simple. Pre-operative assessment is very important. Make the patient lie down, make the patient sit up, and then you'll know exactly how much of subluxation is there. Whether the lens is going back or not. Then anterior posterior support is very important. Either use the capsular hooks or the iris hooks. Circumferential support is very important. You can have a CTR, a Sioni, slow motion Phaco, anticipate PCR, limbal, pars plana, vitrectomy, anterior vitrectomy. If you have access to femto, that makes your life very easy. As I've shown you, have a plan A, plan B, plan C for these patients and anticipate the worst. Thank you very much, Academic Ophthalmology Forum. And this is Dr. Mohan Rajan at gmail.com. I told everybody, please send a mail to me and I will send your beautiful atlas of color, atlas of retina and optic nerve, and in need of blessings and support. Thank you very much.
Thank you, Mohan. I'll ask Dr. Ratish Paul to comment a few comments on your beautiful cases.
I think let me congratulate Mohan Rajan for the beautiful presentation on this subluxation IOL. He made it very beautiful, but only one point, a very small addition. While we are evaluating these particular cases, sir, what we do in our practice, there is a confusion between when to use CTR or when to use an Sionis ring or the Amit segment. Means when we are going to keep it within the capsular bag or when we are going to fix this capsular bag within the sclera. So the physiology or the pathology is very important for this. For an example, for a traumatic cataract at the age of 40, even at the age of 70, it will remain same. This area of subluxation, the amount of subluxation, apart from natural process. But suppose if it is the pathology is PXF, it is a continuous one. Because why I am stressing this, this is our day-to-day experience. I don't know whether you are getting it. We get some cases done, beautiful cataract surgery 10 years before, 15 years before, but enter IOL and the zonular complex is dropped into the vitreous cavity. So this is an important point to keep in mind, that if the pathology is a progressive one like PXF, that had to be had. If it is even the smaller dehiscence, one quadrant, it is better to have a scleral fixation either with an Ahmed segment or the Sionis segment. So this is a small addition. Otherwise, this is beautiful. Very nice presentation once we have seen. Thank you, Mohan Raj.
Now, I just want to, because I forgot to show the video because I didn't have time. The most important thing which I forgot to tell you is that when we have subluxation, there can be vitreous in the anterior chamber through the subluxated area. So make sure that you put, as soon as you go inside, put viscoat. Okay, viscoat, I don't have any financial interest. The Alcon is not paying me a single paisa. I'm just telling you, put viscoat and push that area where the subluxation vitreous. If the vitreous is too much in the anterior chamber, you put tricot and make sure that you do an anterior vitrectomy, either limbal or pars plana, then go in with your capsular rhexis and other things. Okay? Yeah.
So, Mohan, you showed wonderful cases. You also showed pupilloplasty in some of these cases which were traumatic. And if these patients were to have retinal problems later on or now, then what happens to the pupil? I mean, do you have to, what do you do with the small pupil?
We don't do pinhole pupilloplasty.
Okay.
We do about 3 millimeter. Pinhole pupilloplasty is for other indications, which Amar is doing regularly. I'm also doing for that, for irregular astigmatism and all those. Pupilloplasty, around 3 millimeter, you bring the pupil dilates. about 4-5 millimeter. Now we have wide angle fundus cameras, we can take care of the imaging very beautifully without any problem at all. Yeah.
Okay.
If at all the patient develops any detachment, you want this thing, you can always cut off one this thing and dilate the pupil as well. But pupil dilates fairly well. If you make it 3 millimeter, it will dilate to about 5 millimeter or so.
And what about the dead bag syndrome, which people are reporting now more often, many years down the line for uneventful cataract surgeries, like Dr. Ratish Paul was saying? There are cases, where the whole bag is dislocated.
I think dead bag syndrome is a totally different ball game. You must have seen Abhay Vaswada, and they found out there is a genetic predisposition for dead bag syndrome. Okay, the dead bag syndrome, there is a genetic predisposition, and that probably one of the factors. There are multifactorial why it is occurring, and the entire the lens goes back without any reason at all. Yeah.
Thank you very much, Mohan.
Thank you.
One more question, meanwhile, as the speakers are getting ready. Any experience with the cortex? So you've had cortex suturing of the. What is the role of cortex as far as the suturing of the?
Nowadays we are using cortex sutures only mainly. The only thing is it's a little bulky. It's about 6'0", and the cortex sutures definitely over a period of time biodegradation is not seen. The cortex sutures, whatever limited experience, past 3-4 years we are using cortex sutures. It's very effective.
It's very good, especially for the subluxated IOLs and all that. Single piece IOLs, when you want to fix it up, and instead of using 9-0 pulling or 10-0 pulling, we are using cortex sutures.
And as glued IOLs or scleral fixated IOLs are becoming popular, do you think that AC IOLs are extinct and should not be used? What is your opinion? And
I think AC IOLs should not be used. If at all you want to use AC IOLs, there are some centers in India wherein AC. If you want to use AC IOLs, make sure that the cornea is not very sick. Very old patients, still I am using very old patients, and make sure that your pupil is round, no vitreous in the anterior chamber. Don't forget to do a PI. Sizing of the lens is very important.
Dr.
So AC IOLs, I think by and large we should not use.
Dr. Ratish Paul, what's your opinion? Because they've done well. I mean, they've stood by us for last so many years until we modified our normal IOLs to glued
There
IOLs.
was an gross dilemma whether to put, AC IOL or the retrofixated IOL is very popular. But what we are finding in long term for last 15 years, we are practicing it. Of course, not AC IOL, but retrofixated IOL. But one problem is coming up. In case of AC IOL or the retrofixated IOL, we are doing only the anterior vitrectomy because this is mostly done by the cataract surgeon. But honestly speaking, when we see a very young age of a group of patients, 40 years, 50 years, if they don't have the complete removal of the vitreous, especially the base, and in that case, we don't know. Maybe to us it seems the glued IOL or the scleral fixated IOL is a little bit complex compared to your retrofixated IOL. So one criticism against the retrofixated IOL or the AC IOL is whether we are doing the complete removal of the vitreous or the partial vitrectomy, because this leads to future complications in after 15-20 years. This is the experience. I don't know about the hall who has any experience.
Definitely the learning curve for scleral fixation is more than your iris fixated or the AC IOL. The AC IOL is probably the easiest and probably followed by the iris fixated, retro iris fixated I'm talking about. And then the glued IOL and the scleral fixation learning curve a little more. But I personally, I would suggest that we do a fairly good vitrectomy in glued IOLs and you take the help of a posterior segment surgeon for that. Induce a PVD in a patient with glued IOL, but AC IOL and iris fixation you don't require. We can have a show of hands. How many of you are using AC IOL?
How many of you are using AC IOLs? Everybody stopped using. Yeah. And retrofixated IOLs.
Lots.
Oh.
I think retrofixated
and
is
glued IOLs.
Only the retinal surgeon, probably retinal surgeon is
Okay,
there.
few. So retrofixation, according to the show of hands, the retrofixated IOLs, I think, are the most popular. Glued IOLs, I think, still would have to be done in those cases where iris is compromised. because there you can't put a ACIOL or a retrofixation, especially if the iris is atrophied, then in those cases it becomes kind of difficult. But retrofixated IOLs seems to be the most popular option.
And it's quite easy as well, not very difficult to do a retrofixation. Only thing is you need to enlarge the incision to about 5 or 5.5 or something like that. But